Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are very happy to have you join us. As usual, there's always a lot that we need to explore and be aware of, and we have just the right person here to help guide us on questions around prostate cancer. And without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Good afternoon, everyone. I appreciate you joining us this afternoon. We have what I'm going to call one of our Black Health Trust stars from a while back. He's been a friend of mine for a number of years. He's a urologist in Alabama. He's the chief of several services, a graduate of Columbia, a faculty member of Columbia University. And he told me when I had prostate cancer years ago after I had my prostatectomy, eat the blue pill like candy. And it worked. So I'd like to introduce, without any delay, Dr. Brian Stone, professor of urology, member of the fellow of the American College of Surgeons, and appreciate you for being with us, Dr. Stone.
Hey, it's a pleasure to be here.
Thank you.
So how you want to start?
What I was about to say,
Yeah.
what prompted this was what will happen to the rest of us if the most powerful man on the planet who has access to all the health care possible can have prostate cancer sneak up on him, meaning former President Joe Biden. Go ahead, Dr. Brian Stone.
Well, hello there. So I think it kind of validates something that I mentioned to you guys a year or two ago when you had me on talking about prostate cancer. There is a lot of confusion regarding screening and early detection. So much so that we have the American Cancer Society has a set of guidelines. The American Urological Association has guidelines. The National Cancer Network has guidelines. And there's nuance between all of them when there should only be one set of guidelines that people can use. I think the impact of the United States Preventative Services Task Force downgrading PSA about 8 years ago cannot be understated. I mean, it has had ripple effects for the past decade, so much so that in that period that primary care providers weren't screening like we were before this downgrade, we saw almost 15% increase in advanced prostate cancer due to delayed diagnosis. Um, so I'm going to share screen. I just want to show some of the confusion. So these are, can you all see this?
Yes.
Okay, so
Make it full screen though.
let me figure out how to.
There's a little thing that looks like a moving screen in your lower right-hand corner.
Okay, let me see. Well, I don't want to waste time.
Go ahead. Go ahead with it.
I just want to show you. All right, so this is kind of the information that creates some issues, and that's for the older individuals. It says clinicians should take information into account when interpreting PSA values. No, not that one. Special attention should be paid to rising PSA levels in certain populations. And the area of question becomes men who are over 75 years of age. Um, a lot of urologists and PCPs will stop checking PSA at the age of 80. I have a problem with that because I have a lot of intact, active, 90-plus-year-old patients that are still driving, and you can't predict who's going to be viable, how long somebody's going to live. So I think PSA can be checked periodically. And for somebody who is in a position like president or CEO of a company, if they're active and still working, their PSA should be checked just like any other person. Uh, I had some other guidelines. Let's see. All right, this is from the American Urological Association. Here it talks about in 2018, the U.S. Preventative Service Task Force changed the recommendations uh, um, from D to C. But by then, the impact had already been felt. And they still gave a D grade for all men 70 years or older for the use of PSA. So that's m more confusion, making individuals less likely to pursue PSA being checked after 70 years old because they're feeling like they're not at risk, but they are. Um, The American Cancer Society is so vague, it really does not give you any age criteria. And so all of this creates a lot of confusion. And so my position is that if you're a man of African descent, or if you have a family history of prostate cancer, you need to start getting baseline PSAs at the age of 40, and you should continue annual testing until about the age of 80. And at 80, you got to make a judgment. If this is a very viable, healthy, active individual, still working, still engaged, you should continue to check PSAs. You don't necessarily have to perform a digital rectal examination uh, because in the day of age of PSA, we catch cancers long before they create a nodule. Um, and then there's certain nuance to how to interpret PSA. So I focus more on PSA velocity, which is the rate of increase. A PSA of 5 doesn't mean a lot if you don't have any information before that. So if you have PSAs before and the PSA was say 2.3 and within 12 months it went up to 5, that's an abnormal PSA velocity of greater than 0.75 in 12 months. So any increase above 0.75 in a 12-month period is abnormal. If it went from 1 to 1.9, that's abnormal, and it warrants a MRI of the prostate. With the technology that we have now, we're not just biopsying everybody because one of the big concerns was the risk of sepsis associated with biopsies. But it's low. It's less than 1%. So I don't consider that a significant risk. But it has definitely been one of the main reasons why there was such a push against using PSA. But now that we have the MRI of the prostate that allows you to identify lesions, and we now have a new type of PET scan that's called a PSMA scan. It's membrane-bound PSA. This PET scan will detect cancer cells wherever they are. We now have tools that will allow us to make pretty accurate decisions on who needs to have a biopsy and who doesn't. There's also a new push toward instead of doing transrectal uh, uh, biopsies, we do transperineal biopsies. That eliminates the risk of the pool of bacteria that's in the rectum. So there are enough tools out here that no one should be afraid of performing necessary biopsies. And there's enough information showing that you know people are living longer. Men are much more active and viable. And I don't think you should have an absolute cutoff for when you check somebody for prostate cancer. Um, so I think that kind of summarizes my feeling on it. And I think they dropped the ball on Biden. You know, Biden, I think that there's so much we don't know. His mental capacity has probably changed like it did with Reagan. They were probably hiding that from us. But because of his job, his position, he should have been getting evaluated just like any one of us would. He should have been getting his PSAs checked. So, and for him to have metastatic disease, normally it takes at least 10 years for cancer to become apparent and then to metastasize. So I'm just suspicious that maybe they weren't even checking PSA when they said they were. Because
That,
they said the last PSA he had was in 2014,
uh,
which he's 80. How old is he now? He's 80.
82.
Yeah, so 2014 was 11 years ago, which means he would have been 71. That doesn't make sense to me because he had been vice president.
Yeah.
Oh, it just goes to show you that anybody is susceptible to poor health care and poor medical decision making. And you know, when that happens, we have to suffer the consequences. So I'm open to questions.
Are there any questions in the chat? Want to start off that's Neighbor Stevens with any questions? That's Neighbor
No,
Stevens.
no questions in the chat.
Do you have
Okay.
any? You want to start out questioning Dr. Stevens?
Yes, I think that this is an example of one, but there's several categories of recommendations that for one reason or another raise question in terms of appropriateness. And it is an area where you really hope that you have a clinician involved in your care who can make appropriate decisions. So having said that, how can the public arm themselves or equip themselves with the right questions to ask when there is confusing information, shall we say,
Right, right.
around what guidelines, recommendations should be followed?
Yeah. Um, Unfortunately, there's a different value placed on women's health than men's health. The messaging about around breast cancer is unified. That everybody speaks with one voice. The NCCN guidelines, ACS, they all speak with one message around breast cancer screening, et cetera, which I consider an analog of prostate cancer. It's a hormone driven cancer, and prostate cancer is pretty much the same. And I can't understand why we can't get on the same page. A lot of it has to do with men not being vocal and lobbying and fighting, you know. So with that said, it's important that it requires a certain level of personal responsibility. If you're a man or if you have a man in your life, it's important to push that person to just get themselves checked. And when they're with a physician, don't always accept what you're being told. You know, do your own research like you would if you were going to buy a car. Make sure you're well informed or as best informed as you can be, and demand to have certain things done. If you're an active, healthy individual and you're concerned about the things that get us as we get older, the likelihood of cancer increases as we age. You need to ask the question. And if your physician tells you you don't need it, tell them I want to get it anyway. It's covered. Checking a PSA is covered by your insurance. Doesn't hurt to check it.
Yeah. I see Dr. Walks on. Dr. Walks, you have any comments or questions?
Um, I do, uh, Dr. Maxey. This is because I do have a prostate. And I've lost friends at young ages. And I've talked about this before on Black Health Trust. I thought, and maybe I'm wrong, but I thought I remember when they announced um, Joseph Biden's diagnosis that they said that that prostate screening for him was done up until age 70. And what I'm hearing now from Dr. Stone is that it should be done until 80. And
Yeah.
I don't know if we were just getting bad information again or if they actually did that. And if that's part of the confusion or lack of clarity about the screening and when it's supposed to happen.
Well, the care of the president, I think, is typically done in Bethesda, Maryland,
Mhm.
at that military hospital. So they are
Yeah.
probably following the guidelines that a lot of us outside of that institution don't agree with. So
Mhm.
like the urologist with the NMA, we were not satisfied with the position on high risk populations being African American men, so we had to create our own guidelines. So you got another set of guidelines on top of three or four that are already out there that adds to confusion. So the goal now needs to be get a unified message and specifically focus on that older age group because we are living longer. A lot more of us are going to live into our 90s, and the risk of prostate cancer is going up as with each decade. So it just makes sense to check for it. Doesn't mean that the person has to be treated, but at least they got the knowledge of knowing they
Mhm.
have a condition that could kill them, and they have choices. They can decide. I treat 80 something year olds and 90 something year olds with prostate cancer all the time.
So Dr. Stone, if I can just follow up, the other thing, and I've watched um, several stories about the coverage. It it maybe I didn't interpret this right, but it seemed like they were trying to say, "Oh, it's no big deal because he can start hormone therapy or some." It sounded like there was some sort of magic therapy that once the cancer was all in your bones and everything, they can just give you some medicine and make it go away. And I don't think that's how cancer works.
It doesn't work
So if
that
you
way. The more advanced it is when you start treating it, your long-term survival and the morbidity associated with the disease is impacted. Your survival decreases and your risk of suffering from things goes up. The problem with bone mets is that they increase the likelihood of pathologic fractures. Even when we start hormone therapy, it's a hormone-driven cancer. Uh, you're going to put somebody on something that's going to wipe out their testosterone. They feel like crap. If you don't have testosterone, you are as weak as a wilted piece of lettuce.
And
And-
isn't the
and
bone mats painful?
Painful. You may need to get radiation. Um, Maintaining that low testosterone level over time using those medications increases your risk of cardiac complications. Um, no, I mean, it makes sense to catch it early and have all your options on the table. Now, nobody's going to perform surgery on an 80-year-old, but there are things that you can do to mitigate. I mean, I'm actually working on there's a new focus now on focal therapy because of the complications associated with radical surgery and radiation on erections and incontinence. There's a treatment called HIFU, high intensity focused ultrasound. It's been around for over 20 years, and I was waiting for the right diagnostic tools that could accurately identify cancer. And we have it now. We got the PSMA scan and we got the MRI. So HIFU uh, can target the lesion in the prostate and kill it. And then you can monitor the effectiveness of the treatment with PSMA scan. And should the cancer recur, uh, you can still perform surgery, you can still perform radiation. But the data on it was compelling. I was at the AUA convention a couple of weeks ago, and they had the largest series have been performed in Europe, but there are now centers popping up in the US, and I'm actually about to launch a center here in Birmingham because I think it's a viable option. So there's technology coming out now that's going to reduce the complications associated with traditional treatment. And so, regardless of age, I think everybody should know if they have it. So you got all your options. If you choose to do nothing, that's fine, but at least you know.
Dr. Stone, I've
Yeah.
got a set of Simon. Can you put up my slides? I wonder if you mind commenting on some of the slides we have, as well as our co-moderators. Can you put those up for me, Simon?
Okay.
Okay. Let's go to the next slide. So we know that cancer is more treatable when it's caught early. We know
Hmm.
African Americans are often diagnosed later and have a higher death rate. So knowing when to get tested is very important. Go to the next slide. So, Dr. Stone, take it from here if you would for the first few slides.
So, prostate cancer remains the most prevalent or most commonly diagnosed cancer in men. So, you need to focus on that, just like women have to focus on breast cancer. Colon cancer is the most curable cancer we deal with, and that just requires colonoscopy. I do have a problem with patients who only get the Cologuard stool test because of the false negative rate. And I encourage all my patients to get baseline colonoscopies. So if you got polyps, you can remove them. And if you don't have them, you probably, it's safer for you to use the Cologuard test in the future. Cervical cancer, another one, just requires a woman to do her pap smears as scheduled on a regular basis, and you'd be amazed how many women don't. And if you smoke cigarettes, of course you're at risk for lung cancer, and you need to be screened with chest X-rays. And if you could, you need to quit smoking.
Okay. I think the first slide is on prostate cancer. Go to the next slide.
So, African American men have the highest rate of prostate cancer in the world for reasons we're trying to figure out right now. Uh, and I'd say we continue to have a death rate twice that of white men, and that is for a number of factors, including confusion around when to get tested, presenting at a much higher stage of prostate cancer when first diagnosed. Even though it's improved, it remains a problem. Uh, I have at least 5 family members with prostate cancer. When you're in that situation, I don't think it's unreasonable to get a baseline PSA in your late 30s. That's when I started, just to know. But the recommendation is that if you're a high risk male, being African American, or having a family history. Matter of fact, African American is not a good, it should be of African descent, because I don't want men from the Caribbean or Africa thinking they shouldn't be tested. I would start at the age of 40, getting a baseline. Uh, and then even for average risk, I don't agree with that. I don't think it's a big deal to get a blood test when you're 40, if you're black, white, or whatever, so you can know if the rate of increase, if there's been a significant change in your PSA.
Can you comment if you have a first degree relative with a
If you have a first degree relative, if you're white, I treat you like you're African American, and I would start at 40 to get baselines. Because when a cancer is detected, it's been growing for at least 10 years. And so that's it. Family, if your family has a prevalence of prostate cancer, start at 40.
So Dr. Stone, I have a question.
Yeah.
When we look at these recommendations, even the ones that all the doctors agree with, there are still outliers, right? So we say, get that first test at 40, but as I've said on this program before, I had a good friend who died from prostate cancer at 42. So he had it well before age 40. There was something to find. And
Hmm.
so I'm just, I mean, all these statistics are great, but never for
Yeah.
the individual. You know,
Yeah,
I
I
can
mean,
be,
I had
yeah.
when I was at Columbia, I had a kid that was 29 when he was diagnosed, and
Mhm.
his family, he had at least six family members that all were diagnosed young. So that was definitely a genetic
Mhm.
issue. Again, you know, that's rare. So
Yeah.
I think you got to use your judgment. Now, if a patient walks in my office and he's 30 and he's had 4 or 5 first degree relatives with
Mhm.
prostate cancer, I might do a baseline PSA. And especially, I'm seeing a lot more young men with low testosterone that want to go on testosterone therapy. I don't think it's unreasonable to get a baseline PSA before you start testosterone therapy.
Yeah, I
Uh,
don't have slides on, but can you comment briefly on testicular cancer?
Pretty rare in our people. I think I would say just examine yourself in the shower. And if you feel anything unusual, seek out the care of your physician or urologist. Uh, but primary care physicians should be, if you have men under 30, you should be performing a scrotal examination, which most don't. But that's that high risk population, pediatric population up to 30. Um, and then if you have a family that has a high incidence of breast cancer, because the BRCA genes are associated also with increased prostate cancer risk, I would treat those men just like men with family history of prostate cancer.
Okay, thank you. Let's go to the next slide. Maybe Dr. Neighbor, Dr. Neighbor Stevens. So we're talking about
I
breast.
apologize. I keep putting it on mute because of the thunder. Um, Breast cancer. Who's most at risk? Black women more likely to be diagnosed with aggressive forms. When to start testing? Start annual mammograms at age 40. Earlier if there's a family history. And down below, there's a bullet on test, which I can't see, but I was going to bring it up. That's another area of controversy. What test to use, especially in younger women who have dense breasts. So there's another area of controversy with breast cancer. There's a recommendation out there that you don't need breast screening after the age of 74. And I had a conversation with my clinician who said that she does kind of a similar thought algorithm to yours, Dr.
Yeah,
Stone.
yeah.
She looks at whether or not the person has a reasonable chance of living for at least another 10 years, the activity in their life, the quality of their life, and if the patient wants it. And if they do, she continues it beyond that cutoff.
Hmm.
Hmm.
I agree.
Let's go to the next slide.
And may I just add to that?
Go
That's
ahead.
an example of where you need to have the conversation. I was aware of the guideline and I was debating whether or not I needed to continue having that test done. And so I raised the question before she even had a chance. I raised the question because I wanted to know, I was aware of the whole controversy around prostate cancer. I was suspicious that it was some of the same dynamics in play.
Hmm. You were correct.
All right. So Dr. Wilkes, you want to take this one?
Uh, Colon cancer. Who's most at risk? I'm gonna I'm gonna go with Dr. Stone and say people of African descent have the highest rates of colorectal cancer and earlier onset. When
Mhm.
to start testing? Start at age 45, earlier, if family history or symptoms. And then I can kind of see down at the bottom, test colonoscopy would be the gold standard.
All right, let's go one more slide. Dr. Hines is not here this morning, right?
No,
So this is in your area too, Dr. Stone?
I agree with these guidelines. Start testing at the age of 21. A lot of girls are sexually active early and have been exposed to the HPV virus. And I would say that kids should receive that HPV vaccine. That'll reduce their risk going forward. And you perform a pap smear and HPV testing up until the age of 65. Now, I'm not a gynecologist, and I would use the same uh, thinking that if you have very viable, active women, I have so many 90-year-old women that I think is reasonable to continue checking as women get older. And I can't see the bottom
I can't say, but I think this is every 2 years.
every 2 to 3 years. Yeah, and I think that's reasonable because cervical cancer is devastating.
Okay, let's go to the next slide. Will you comment? What does a urogynecologist do? What do they
So
do?
these are gynecologists that get a fellowship in urology, and it kind of provides additional training in the area of bladder function, because the bladder and the vagina are intimately connected, and problems with one can affect the other.
Okay, and lung cancer. So who should get tested? Adults who are in the 50 to 80 range who smoke, especially people who have a 20-pack year history. And the tests that we recommend are low dose CT scan, and this should happen every year if they're still at risk. Lung cancer can be a major diagnosis. So if you've been a smoker, especially with a 20-pack year history, you definitely want to get looked at by this CT scan. Next slide.
Oh, one caveat, I work in an area that has a lot of coal miners. So if you worked in a coal mine or you're in a place where you're exposed to toxic type conditions, you should be checked as well.
Okay. And the normal things that we talk about all the time are high blood pressure, diabetes, cholesterol, and HIV things that we test for. Make sure you keep up with those as well. Next slide.
Oh, I got a comment on blood pressure.
Okay.
I'm in disagreement that 90 uh is okay as a diastolic level. I think for Black people, because of a high risk of kidney disease, your diastolic should be less than 80.
Absolutely right. Absolutely right. We've talked about that. So everybody knows that the 120 over 80 is the actual top of the blood pressure that's acceptable. Next slide. Thanks for bringing that up.
Hmm.
I'll
Uh,
take this one because I want to loop a question from the chat into it.
okay.
Overcoming barriers, access and costs. Ask clinics about free or low-cost screenings. That is access and co insurance coverage are definite issues that have to be addressed. The there was a question in the chat about whether the PSA was covered, and I'm going to turn that part of the question over to Dr. Stone, who knows.
Yes, it is. It's covered, and if it's normal, you're allowed one per year. But if you have a history of abnormal PSA, you can get multiple per year,
no matter what your age, Dr. Stone.
regardless of age. If you have an abnormal PSA, which means you're at risk for prostate cancer, You can get PSAs as you need, and they will be covered.
Unfortunately, that is not true for some other tests, including breast screening.
Yeah.
However, there are ways around that as well. Many health departments do free breast screenings if you fall outside of the age range that is recommended for breast screening. Mistrust, bring a family member, ask questions. I can't say that enough. I've been harping on that ever since we started. Fear of results, early diagnosis saves lives. Knowledge is power. Yeah, absolutely. The earlier the diagnosis, the greater the chances of dare I say cure. But unfortunately, there are some cancers that we don't quite yet have cures. But in general, the earlier the diagnosis, the better your chance for at least a longer life and a better quality of life.
And I got one other comment on that. Don't be afraid to get a second opinion.
Definitely.
And if you're hearing it twice, that means that the first opinion was probably correct. But it's your right to ask for a second opinion.
So, by the way, I just got a beta test for a thing called Dr. Dre, mean Dr. AI.
Uh-huh.
It's a beta test on a second opinion product. I'm going to send it to all my co-moderators just to check out. But second opinion is so important, and you deserve that, and Medicare will pay for it. Let's go to the next slide, which I think should be last. You want to talk about this, Dr. Stone?
Well, I would say number one, having the proper primary care physician is a must. I mean, I've had to fire mine because he wasn't a good communicator. And I would end up, he was my friend. I'd end up telling him what to do on me because he was so damn nervous. So I had to fire him. I need somebody to care for me. It's important that you know your family history. And right now, I serve on a board of the Catalyst program, and it is a program that's bringing free genomic testing to Alabama, all communities, because medicine is moving toward precision medicine. And that means treatments that are tailored to you based on your genetic makeup. So in the future, it's important to educate yourself on genomic testing and not be afraid to get tested because a lot of these diseases that are recurring over and over in your family potentially have a genetic cause, and it's good to know, and it's good for your family members to know. Make sure you understand the proper ages for getting certain tests. And that means having the right primary care physician that should know these things. And as these tests are performed, you should hold on to the results. Because I get patients that have had PSAs checked at different offices. They have no idea what the last PSA was, and knowledge is power. You know, it's not all on your physician to save you. You got to protect yourself, and you do that through knowledge.
Oh, yeah. So, Dr. Walks, I'm going to ask you for a comment. I'm going to make it. I heard Dr. Brian Stone say it. He says, your doctor should not be your friend. He needs to be your doctor. I think your parent should be your parent and not your friend.
Correct.
I would so Dr. Maxey, I was going to ask Dr. Stone when he fired his friend as his doctor, did he fire him as his friend as well?
No, we're still buddies. He's still referring me patients.
Okay. And you know, one of the things that I know we talked a lot today about um, screening and diagnosis. But when we look at causes, um, I think it's hard for me to see where I am now, but it looked like Dr. Lawson put something in there about depression and maybe other mental health challenges as they impact the incidence of some of these challenges we're talking about.
Well,
Good.
we don't know the cause of prostate cancer yet, but I'm with a group called Conduct, which is all of the black urologists, top black urologists, oncologists, radiation oncologists in the country. We're working on something called the SCOPE registry trial. We're trying to create the largest database on African American men with prostate cancer, which will help us start to gather some answers. I mean, we have spotty information. We have a few genes that we know are in African Americans that increase your risk of prostate cancer, but we just don't have a large enough pool of data to make statements. So that's what we're working on right now.
So Dr. Stone, to that point, I would think, and I would be bold enough to say, as not any kind of urologist, either a top one or a bottom one, I think that we have plenty of information to say that we're still working on why the incidence of prostate cancer is higher in people of African descent. But I would I would submit that the higher death rate may have more to do with stuff we can change today, like
Absolutely.
access and fair, equitable treatment and those kinds of things.
And that's been borne out in a VA study where, allegedly everybody has equal access to care. And there is a difference in mortality, but the behavior of prostate cancer is still more aggressive in Black men. The
Okay.
other confounder for us is that the genes from Africa linked to prostate cancer were disseminated in the Caribbean, Brazil, Africa, but the cancer expression rates remain higher in African American men. So it's something about being in America. We don't know if, slavery was harder. I don't know what it is, but there's something different, probably environmental and diet, that are kind of
Mm.
contributing to these higher levels that we're seeing. But
Uh,
that's why we need more data.
Okay. Let me see if Mr. Barbie can be unmuted. Dr. Barbie, Rudy Barbie,
Layman, Dr. Maxey.
how are you, sir?
I'm
Yeah,
fine. I know I gave a protracted thing in the text, but so if I could, Dr. Stone, I'd like to read it to you.
Go ahead.
I have uncles that did not pursue aggressive treatment and died. My father did not either. He had work done in Norris and Kaiser and Mayo and had his actual surgery done with a Gleason 8 score, longest survivor,
Uh-huh.
pursued the nerve sparing, as I would call it, nerve sparing surgery, just as General Schwarzkopf and a lot of other high
Hmm.
end folks had at the time. And so he's in his 90s now. So we're talking from 96 to now.
Hmm.
So I am cognizant of my risk association with near relative, as you previously mentioned. So I
Hmm.
challenged my neurologist after reviewing my trends, my graphs of my readings, and they went from 3.4 in 2014 to 8.4 in December of 2024. Now, my question to you, well, I have two questions, but first question was, there was a average baseline that I was supposed, not baseline, it was an average limit that I was supposed to have of 4.5. And up until from before 2014 to 2024, early 2024, 4.5 was the limit, i.e. the area of concern if you got over that. But then in later 2024, it went to 6.5. And I don't know why it was raised, and I didn't get a clear answer from the
Yeah.
urologist.
So did you have a white urologist?
No, sir.
Damn. So we made so I'm a member of R. Frank Jones Urological Society, which is a black urologist. So we based on a study that was done by Ian Thompson, who was a Air Force urologist based in San Antonio. He did a autopsy study just looking at the prevalence of prostate cancer in men that died from other causes. And he found that in each decade, prostate cancer was present. So he extended that further to try to break it down by race. And one thing about black men, we have a higher volume of prostate cancer uh, per level of PSA, meaning you got to be suspicious of changes in PSA and not pay any attention to absolute levels. So if you had a PSA that was one year and it went up to 2.5 the next year, that's abnormal. That person needs to be worked up. They need an MRI, they need some other things, biopsy or whatever you have at your disposal, because they're at risk. And if you're in a high risk population like us, you got to pay more attention to changes in PSA than the absolute number. Uh, so I would have worked you up differently. That's
I,
all I'll say. I'm very aggressive in managing uh, brothers because of our risk.
and I'm not being argumentative, but when I went from 3.4 to 6.1 in 9 years, I mean
Yeah.
in 7 years, there was I just looked at the trajectory, and I'm not a doctor, but I do know math, and I just
Have
didn't
you
think that was
did
good.
did you have
But
an
I went,
MRI of your prostate?
you know, I I haven't. I've had two biopsies. One
Yeah.
I bled a lot, and one I didn't bleed at all, like the second time.
Yeah. So
How close,
MRI is the
how close are you
standard.
to Birmingham?
It's the standard of care, MRI of your prostate, because you can see, and then you do what you got to do.
All right, I'll specifically ask for that this year because I'm due for
You need to call and ask for that this week.
I will make an email after this call.
Now,
Thank you.
one of the issues though, certain insurance companies, particularly Blue Cross Blue Shield, they can be a little difficult about getting an MRI without having had a biopsy in the past. Um,
Well, I've had two of the 14 shot
Biopsy, okay, then
biopsy.
you're good.
Yes,
You
I'm
should
good.
have, yeah, you need an MRI like immediately.
I've been taking prostagenics, and I went from 8 to 7.9, and then I didn't take it for 6 months, and I went to 8.4 last December. So
But
I
prostagenics is some BS. It hasn't gone through any clinical trials. I wouldn't
well,
put
right.
my faith in
Okay.
that.
No, and I did, and I was just saying I did some
Oh,
dietary
okay.
stuff too, but okay, I got the drill. I will post haste send in my email for an MRI request.
Okay. And I'm
Uh,
talking to you. Hey, if we didn't have an audience, I'd be cursing at you right now.
Yeah,
Okay, okay.
yeah, we had this yeah, I got it. Thank you.
So let me can I
I,
jump in, Dr. Maxey?
I want
Let
to
me jump
find
in
out
for a minute.
about prostate cancer in the Caribbean. Go ahead.
Okay, wait. Before we do that, I want to talk about what just happened with Dr. Stone and the amazing and wonderful Mr. Barbie.
I'm
Because
just a regular guy, doctor. Go ahead.
you know what? You stop that. You stop saying that because all of us are fearfully and wonderfully made. So there
Yeah.
you go. Take that with you. But
Yes,
but
sir.
but but listen. When we talk to people about their risk, it's scary.
Yeah.
And a lot of folks who look like us, I don't, we have songs. Don't nobody bring me no bad news. I don't want to know about that. I don't want to think
Yeah.
about that. And I actually talked to a younger person this week who didn't want to do any, I don't want to go to the doctor once a year. I don't want to get this because if something is going to kill me, it's going to kill me. And I just don't want to know. And I think that we have to begin to really address that with young people so that they understand it's not bad news, it's news.
Yeah.
And we need to understand what's going on. So I just want to throw that out there.
Well,
Yep.
you also, doctor, there was Real Men Can Cook, I think started that, and then it kind of evaporated. But I'll just tell all of you, particularly Dr. Stone, because he was Dr. Stone, last year you did make a comment, so I didn't forget about it.
Okay.
But and I took issue with my urologist and blah blah blah. But um I have a friend who's supposed to get prostate surgery, I think this week. I'm going to check. And Dr. Walks, I'd never heard, and I really rarely say this, I'd never heard a more obstinate individual
Mhm.
about getting treatment from a doctor. Oh, they just want the money. I said, no, he's trying to save your life and your quality of life. And so I,
Yeah.
I got indignant with him too. I was thinking to myself, I think you waited too long, but maybe not. It was just the attitude of not going in. He didn't have the candid conversations I've had with my urologist, which is why I can say to you today what I said. Um, and only now is he starting to listen, and that's it's really down the path. So I guess there's a lot of us with that melanin that's just got it, but I think we need to get reoriented as to why our brothers and sisters go through all this training and get this information and get conflicts and issues and talk about consortiums that Dr. Stone talked about and the
Yeah.
like. And we just have to get out there and do the barbershop or do some kind of a thing more often because I'm 70 and I'm talking about stuff that I focused on from 2014 and I've been staying on it with the graphs and everything. But I got some folks younger than me that's just checking out because I think they waited too long.
They need
Yeah,
help with Dr. Walks and Dr. Lawson as well.
this reinforces the importance of second opinions. You got to go around and check and make sure that what you're hearing is correct.
Yeah. So is Dr. Lisa Dawes on? Is Dr. Dawes on, Dr. Walks and Dr. Neighbor Stevens? I
So
think
somebody's got the hand raised. Dr. Sherrod.
Dr. Sherrod, open Dr. Sherrod's mic if you would.
Well, good afternoon. I just want to commend Dr. Maxey again on another outstanding session and the brilliant Dr. Stone. Really enjoyed what you have had to say here today. I missed part of it. I missed about 15 minutes, I think. But I have a question and then I want to make a statement.
Hmm.
I'll make the statement first. I'm baffled that we're still puzzled about the reports of everything being worse outcomes in Black people. And maybe I'm oversimplifying it, but I think it has a lot to do with the lifestyle in America, the diet, which is the standard American diet, which stands for SAD, and the fact that we're under chronic unremitting stress, which is the racial
Yeah.
discrimination and all the other things that come with that. So I think we have to actually focus on how we can, and we've been doing this on the Black Health Trust because we've been talking about food and trying to get people to change their diets and be aware of all this ultra, processed food and all that kind of stuff. But my question is concerning the pap smear, because I went in to get a pap smear and the lady told me, well, you don't have to do it every year anymore, because you're over 65. So my question is, how often should we be getting the pap smear if you're over 65 and you're a Black woman?
I'd say the 3-year interval is okay, and I would caveat it with if you don't have atypia or HPV found. If you've been smeared and you got the presence of HPV, that probably means you need to get checked yearly because the presence of HPV increases your risk of cervical cancer.
So
But
are they automatically doing HPV now culturing with the pap smear?
yeah, they check it'll turn up in the when they do the cytology, they can see if there's HPV present or not.
Oh, okay, that's new to me. And
Yeah,
they are
and,
reporting
and if
that
you
out.
haven't been told that, then you're in a good category.
So so
Yeah.
so just to clarify, I think Dr. Sherrod's question was, are they doing it? And I think Dr. Stone, your answer was they should be doing it. So
I
Right.
think
I'm not I'm
following those guidelines, I'm a urologist. I don't do it, but I
Right.
always ask all my patients, the females that are in that risk have you had your pap smear? And I look at it, and if I see on an old one they've had HPV or atypical cells, I tell them you need to be getting checked every
Yearly.
year because your risk of cervical cancer is higher than if you didn't have that. But I always refer to a GYN because I'm just a plumber, but I pay attention to it because I'm down in the area all the time.
But also taking into
All
consideration
right.
what you pointed out earlier, that if you're a Black woman, you probably should be getting it anyway,
Yeah. There's nothing
every
wrong with
year.
getting a negative test.
Right, exactly. But I mean, I had to fight my gynecologist to make her do the pap smear on me. I said, I want one, even if
There,
I'm not due for one. I want
there
it.
you go.
Yeah.
Protect yourself.
Hit her with a
Yeah,
left
you have
hook.
to take responsibility for your own health. And people don't like, a lot of physicians don't like you to do that though. If
Uh,
you challenge them or confront them, they get upset.
then switch.
Find another doctor then.
Uh, I
That's
see
it.
a hand raised from a W. Lawson.
Dr.
Yeah.
Lawson, go ahead.
Yeah, I just wanted to note that a while back there was a lot of attention paid to the relationship between depression and breast cancer. We did studies looking at common genes and so forth. But an interesting thing was that I hadn't heard much about that lately. I know there are some studies not showing a relationship. But what is standing out is that early traumatic events early in life seems to increase all kinds of problems throughout the lifespan. And I don't know if there's been any specific cancers that's been linked to that, but with everyone getting depression screens, and I was just wondering if there's anything more in terms of that, and also how much of that confounds the whole issue of the racial disparities because people who are depressed simply don't get follow-up treatment as well as people who don't get depressed.
In relation to what you're saying, Dr. Lawson, I did a talk on APLO1, kidney disease, and there's something called a second hit theory, that the gene changes sometimes get activated by stress and by racism.
Right.
And that's not cancer, but that stress and racism can certainly play a role, I believe, in making that gene may not unlock it until the stress by the mental stress and the racism.
Right.
We're almost at the top of our time now. Let's get our final last comments. Any other questions, Dr. Neighbor Stephen, in the chat?
There is a question comment regarding something that we probably need to address in a future show, and that is, are we at risk from plastic and byproducts? I think the evidence is pretty clear,
Yeah.
but we can certainly talk about that at length in another show.
Then I'd like to very much thank Dr. Stone for coming on the show and talking about prostate cancer. I'd like to give him the opportunity to have final closing comments, Dr. Stone.
I think the message from what happened to the president is that if it can happen to the president of the United States, it can happen to you. So it's important for you to take responsibility for your own health and don't just put everything in the hands of your physician because, as you see, there's a lot of confusion even with physician recommendations, so it's a reason for you to read up on the things that you're at risk for. So when you go in the doctor's office, if you see something not being done, request it. And if a test is performed, ask for a copy. If they're doing a PSA, get a copy of it, keep it in your records. You should know your PSA level as well as you know your blood pressure or your weight. And that applies for everything. Don't be afraid to get a colonoscopy.
Thank you very much, Dr. Stone. Can you give us your location and address in case anybody wants to fly to Birmingham like I'm going to do?
All right. So my office number is 205 384 3013. If you have personal questions, you can call my cell phone 205 910 3595. and my email address is bstonemd59@gmail.com. And I take care of people from all over the country. I'm happy to help you. You can give you advice or anything you need.
Thank you so much. I appreciate it. Dr. Walks.
I just, listening to Dr. Stone is informative and it's heartening. It's good to know that there are folks out there who are willing to ask that next question and listen for that next answer. So I just really want to thank you, Dr. Stone. This is
Yeah.
I know so many people that look like me that have had prostate cancer. No one in my immediate genetic family to this point, but just so many people that I know. And this is really a big deal. And so when I hear brothers like you who know what you're talking about and are willing to talk about it and are willing to talk to people, it's a good thing, man. Thank you. Appreciate that.
Appreciate it. And Randall, share the op-ed that I was asked to write for DC regarding the impact of the cuts.
Why
We're
don't,
headed
why
for
don't, why don't you give a 2-minute summary of what you wrote?
Oh, basically, I testified before Congress last June regarding the physician shortage. We're retiring 71,000 a year. We only graduate 21,000. And so
Wow.
the impact of physician access is going to get worse. And these cuts are about to make things extremely bad.
Yeah.
The Medicaid cuts, the cuts to the NIH. I had two grants of mine that were cut. I had scholarship at UAB for Black medical students because of this DEI law. They've returned all the scholarship monies to Black folks that had scholarships. So we're in a dark place, and we're going to have to be much more engaged like our parents were back in the 50s, and it's coming. So get ready.
Thank
Mm.
you so much.
Get
Dr. Barbara Davis Stevens.
Well, as I've almost every week feel, I think the message that we are putting out into the universe through this discussion is information that you're not going to get anywhere else. Please
Mm.
share this, the fact that you got this information, where you got this information, and encourage people to look at us on YouTube or FaceTime or live on Sunday. For as long as we can, we will try to keep you informed with vetted information.
Thank you so much. Thank you, everybody, for joining us this afternoon. I want to encourage everybody, if your physician does not do what you need in terms of really looking into your risk factors, fire him and get another one, but certainly get a second opinion. Don't be bashful. It's your body and your life. Thanks for
But keep
everybody.
them but keep them as your friend.
Oh yeah, keep him as your friend.
He's your friend. Maybe, according to how bad they treat you. Thank you, Simon. Have a
Hey,
great
thank you guys. I appreciate it.
All right, bye-bye.
Bye.
Good day, everyone.